Hi friends, welcome to Sonobuzz workshop on neurosonography. I am Dr. LULLA from RIA Clinic, Mumbai. We are going to discuss today fetal basic and advanced neurosonography techniques. We will be using the Voluson E10 new BT21 machine. We'll use the E8 and we'll use the Logic E10 all G machines, and we'll show you different techniques of basic and advanced neurosonography, and hope you can use these techniques in your practice, and we'll show you some cases also. Thank you. Let's start. So when we talk of neurosonogram, we are basically looking at basic and advanced neurosonogram. Basic is what you're expected to do when you do a routine scan, and it's usually transabdominal with 3 to 5 megahertz probe. Essentially involving only grayscale or sometimes even color Doppler. We use harmonic imaging. When we talk of advanced neurosonogram, it is essentially transabdominal, but we can also use transvaginal transducers, especially if you have a vertex presentation, and if it's a breech, we use a transabdominal transducers. We use higher frequency transducers because there is more information that is sought after. We also use 3D ultrasound with grayscale and power Doppler imaging, and a lot of 3D tools in the form of volume contrast imaging. So advanced neurosonogram involves thoroughly looking at the entire brain with multiple sections compared to just the basic axial sections. So basic examinations involves 3 planes: the transcerebellar plane, the lowest plane, the transthalamic plane, and the highest plane is the transventricular plane. So that is the transventricular plane. This is the transthalamic plane. This is the transventricular plane. You can see the margins of the lateral ventricle. The near ventricles may not be seen as clearly. That's the cavum, septum, the frontal horns, the occipital horns, and that is the transcerebellar plane, which is the lower plane which looks at the cerebellum. And we also look at the spine. In the basic examination, we look at the end of the cord usually at L2, L3 by about 24 weeks. Now, here we see that transabdominal imaging may sometimes not be appropriate, especially in a very high BMI individual or early in pregnancy. You can see that there is a suspicious cystic lesion here in the brain, but we really cannot make out. Even with volume imaging, we have done TUI, but you can't make out the origin of this cystic lesion. And the same patient we see transvaginally, you can see that that's actually a dorsal cyst communicating with the ventricular system, and the frontal horns are fused here. So this is like a very mild holoprosencephaly with a dorsal sac here, as you can see. So transvaginal imaging is really useful. Now this is the 3-horn view. I just put this because to highlight that we usually don't like to image obliquely to see the near ventricle. As I told you earlier, the near ventricle can sometimes be difficult to see, but it's useful especially when you are looking at asymmetric or unilateral ventricular megaly and you want to see the margins. It's irregular to whether there is any nodular heterotopia or box-shaped ventricles suggesting cortical disease. So in most other situations, we prefer a posterior coronal view and where we can measure both the near and the far ventricles. When we talk of biometry, these are the standard biometry measurements that we do. We identify the parieto-occipital sulcus and look at the occipital horns. We measure the cavum both in width and length. We measure the transcerebellar diameter and the cisterna magna. There are a lot of other measurements which may not be useful. Now this is a new technique called Sono-CNS, auto-Sono-CNS, where the Voluson E10 grabs the volume, as you can see here, and the machine itself creates all the sections, all the 3 sections, axial sections, and also gives us the measurements automatically. So artificial intelligence is used to give, and the planes are absolutely perfect, and you can see that even the ventricle is measured accurately, even the cerebellum, cisterna magna, and this is really going to be useful in the future. Now, what are the limitations of the basic neurosonogram? It depends on the time dedicated to the scan. So if you're doing a very rapid scan, a basic neurosonogram will not give you a complete information. Also, it is to be done by people who are not trained or have basic level training. So these are some of the limitations. Sometimes all the views are not accessible, especially in mid gestation. Fetuses are in horizontal lie, and some sections may be difficult to obtain, especially the midline sagittal plane. And these are some techniques. You can see here that this is a fetus which we are pushing with the hand. So we use both the hands, one hand the transducer, the other hand we move the fetus into the view, and you can see that this is actually a fetus lying deep, and you with the hand you move the fetus into position, and you can see the corpus callosum and the cerebellum. So very useful and important to use both the hands when you scan and do an advanced neurosonogram. And here this is an axial view, just pointing out that most of the times we do a neurosonogram between 18 and 37 weeks with a BPD of 44 and 88 millimeter, just like you do the NT scan between 11 and 14 weeks. Now, when we do a basic scan, we identify the anterior horns, the cavum, septum pellucidum, the choroid plexus, and the occipital horns. This is the transthalamic plane, the transventricular plane with the fox going through and through, and the medial margin of the lateral ventricle at the level of the parieto-occipital sulcus. And at the lowest section, we look at the vermis and the thalama. Advanced neurosonography involves visualizing more or multiple sections either through the anterior fontanelle or through the posterior fontanelle, and we press at the transducer at the level of the fontanelle, either by the transvaginal transducer or if it's a breech, transabdominally. So you use whichever fontanelle, but preferably the posterior cranial fossa is better visualized from the posterior fontanelle, and the anterior cranial fossa from the anterior fontanelle, as you can see. And we get these lovely midline sagittal images. That's the corpus callosum, the vermis, and that's the midbrain here, and that's the fourth ventricle, third ventricle, and these are better obtained. So how do we do it? We take multiple coronal, sagittal, and axial planes. Axial planes are the same, the three axial planes. In coronal, we take 4 planes, the transfrontal plane, which is the furthest plane where you can see the olfactory sulcus here. And then the second plane is in the frontal horn level, where we see the cavum, septum, and the corpus callosum, the anterior complex, the cingulate gyrus. And this is a little transthalamic plane, the third coronal plane, again showing you the anterior complex. And the fourth plane is the occipital horns. As I said earlier, we measure both the ventricles in this plane, and we don't use the oblique plane for measuring, and you can see there's asymmetric prominence of the lateral ventricle. So that's the transcerebellar plane. And if you have a volume, you can use the volume imaging to get all the planes in one volume. You can scroll through the volume, as you can see in this particular image. Now, the sagittal images, similarly, we take 3 images, one in the midline, 2 on either side. So midline is of course used for looking at the corpus callosum, and then on either side we look at the lateral ventricles, the 3-horn view, as you can see here, the frontal, occipital, and temporal horns, and then we look at the sulci and the gyri very peripherally in the sagittal view. So in the sagittal midline image, most importantly, we are looking at the corpus callosum, and so we look at the rostrum, the genu, the body, and the splenium. It ends at the level of the tectal plate, and that's important. So we must have the entire corpus callosum ending at the level of the tectal plate. Then you can look at the cerebellum, the fastigium, and that's the fourth ventricle out there. And of course, if you have volumes, you can scroll through the volume from side to side. Now, the color Doppler is also very useful in identifying, then it's an indirect sign for identifying the pericallosal artery, identifies the corpus callosum, as you can see here. And here this is slow flow imaging, which is used here to highlight all the pericallosal artery and its branches, confirming the presence of the normal corpus callosum. And this is useful for biometry. We measure all the sizes of the corpus callosum, the width and the thickness can be measured. And of course, we also measure the vermis in both superior inferior dimension, AP dimension, and we can measure the area and relate it to the head circumference. And there are charts available, and you can see all the fissures of the vermis. So this imaging is done from the posterior cranial fossa, and you can see the midbrain, the pons, and the medulla oblongata. So you have both the midbrain and the cerebellum. You know that when there are genetic disorders, both of these, there can be pontocerebellar hypoplasia, because many genetic conditions can involve both these conditions. So we need to measure all the diameters. You can also do surface rendered imaging of the cerebellar folia, especially useful for conditions like rhombencephalosynapsis, where we don't see a vermis and the folia continue through and through. And you can also see the blood supply of the cerebellum and the pericallosal artery in this particular view. So a lot of 3D surface rendered techniques to capture the volume, both in, as showed you earlier. So you can see that that is the calcarine fissure here, the occipital horns, the cerebellum, the tentorium. It is so well highlighted on the surface rendered 3D imaging. And then we measure the angles. So that is the brainstem Vermian angle, the brainstem tentorial angle. And you know that when we have pathological conditions like a Blake pouch cyst, the vermis is rotated in an anti-clockwise direction, and an average angle will be of about, say, 9 degrees is normal. Anything up to about 23 degrees can be due to a Blake pouch cyst. A Vermian hypoplasia can have a higher angle of about 35 degrees, and of course Dandy Walker can have a higher angle of about 63 degrees. We also look at in an advanced sonogram the development of the sulci. Essentially after 20 weeks, we focus first on the parieto-occipital sulcus, because that's a landmark for measuring the lateral ventricles. We also look at the calcarine fissure, as I said, in the coronal plane, and the cingulate fissure in the sulcus in the coronal plane frontal area. And there is a lot of information available on the symmetry and asymmetry of these fissures on either side. So you can measure both the sides of the sulcus, and we look at these. The predominant sulcus that we look at is the Sylvian fissure and its sulcus. It's usually initially obtuse, and as time passes by, it closes down and becomes acute, and that tells us that there is good cortical development. This is a very good coronal view. It's called the toast view, where you can see the Sylvian fissure in the coronal view. This is very early, it's about 19-20 weeks, and you can see that it's obtuse, and it's a useful view to see the Sylvian fissure and sulcus here. And this is at about 21 weeks. You can see that the fissure is obtuse. So also in the coronal view, you can see it here. And as the fetus goes on to about 28 weeks, you can see that the sulcus has closed. It's no longer, it's acute, and even on the coronal view, it is appearing like a Y sign. So it is completely closed here. The sulcus is closed. So now we will do the workshop, and we will show you two cases, transabdominal and transvaginal. The first case is transabdominal, and the second case will be transvaginal. We are doing today the neurosonogram. This is a breech presentation with the head on the top on the right side, and it's about 28-29 weeks. This is the axial view, the typical transthalamic view, where we measure the BPD and the head circumference. And then we move to a slightly higher plane, where we look at the parieto-occipital sulcus and we measure the lateral ventricles. And we also look at the cavum septum pellucidum here, which highlights the fact that the corpus callosum is intact. We can measure a ratio. That's the diameter of the cavum septum. We can see the sulcations high in the cortex. They're all intact. And as we go down at the transthalamic level, we see that the Sylvian fissure is closed. And this is the axial plane. And the third axial plane is the lower plane, the transcerebellar plane, where we record the transcerebellar diameter, the cisterna magna, and we look at the vermis. So vermis is echogenic, the cerebellar hemispheres are hypoechoic. So these are the three basic axial planes. As the fetus is moving, we can see the opposite ventricle also. You can notice that that's the size of the opposite ventricle. And sometimes we can get a coronal and sagittal view. We'll just see if we can get a sagittal view. We have to manipulate the fetus a little bit. And that's the coronal view of the cerebellum. You can see the cerebellar folia, the tentorium, the sulcus here. This is the coronal view from the frontal aspect. So these are the frontal horns. That's the fox cerebelli, cingulate gyrus, sulcus. As I go forward, that's the cavum septum here. The frontal horns are here. That's the corpus callosum. And we go posteriorly, that's the thalamus and the choroid plexus in the lateral ventricles. We also look at the spine. That's the cord here. This cord usually ends at L2, L3. That's the termination of the cord. That's L2 level vertebrae. L5 is identified by the pelvic bone, and then you count upwards, and that's the L2, L3. The last thing left is a sagittal view, a mid-sagittal view, and that can be sometimes very difficult, especially later in pregnancy. And you can see here that we may use even color at times to identify, but we are not getting depth penetration due to the large size of the fetus. That's the sagittal view showing the choroid plexus in the lateral ventricles. These are the sulcations. I am trying to come in the midline. The fetus is a little bit flexed. And we're not getting a very good sagittal view, so we'll just see from the other side. Yeah. This is a better view. You can see the corpus callosum beautifully now. The entire length of the corpus callosum. We can measure the length of the corpus callosum. You can measure the thickness at various levels. They are usually symmetrical. And that is the vermis. Actually, we are scanning from the anterior aspect, so the vermis is not very well seen, but roughly you can see that that's the vermis. We measure the length of the vermis and the AP diameter. And we will try again whether we can see the blood flow. Yeah, now we can see the beautiful pericallosal artery, which highlights the presence of a normal corpus callosum. That is the straight sinus here and the superior sagittal sinus. And that was with power Doppler. This is with regular color Doppler. You can see the difference that power Doppler makes. This is the cavum septum here, pellucidum, the thalamus. That's the tectal plate, the midbrain, the pons, the fourth ventricle. This diamond-shaped structure is the fourth ventricle, the pons, the midbrain, the vermis, and this is the thalamus here. The massa intermedia. So that is the sagittal plane, 3 sections in the sagittal from one side to the other, 3 coronal planes or 4 coronal planes from the front to the cavum, thalamus, and posteriorly the cerebellum, and 3 axial planes as we saw earlier. Cerebellum best seen in the axial plane, and you can see the fourth ventricle again in the axial plane very well here. That's the cisterna magna, usually less than 10 millimeter. It's about 11, which is normal. This is the hippocampal sulcus, and the parieto-occipital sulcus is higher. That's the cavum here with the frontal horns on either side. The anterior complex, the corpus callosum here. Hello friends, today we are going to talk on neurosonogram. As you know, we have a basic neurosonogram and an advanced neurosonogram. Now, in many ways when we scan, we do both the components together. And especially if there is something wrong. Here, of course, we were doing a transvaginal scan because the cervix is completely open, and in that process we are now seeing the fetal brain. So we are first doing a coronal scan, and we take about 4 sections from posteriorly. You can see that is the cerebellum here. This is the occipital horns of the lateral ventricle. This is the parieto-occipital sulcus. And that is the calcarine fissure here, and that's the calcarine fissure. And then we go ahead, and these are the bodies of the lateral ventricle. It's a coronal view of the cerebellum here. You can see that's the vermis, and as we go forward we see the thalamus, and that's the corpus callosum. The mid portion, that's the cavum, that's the frontal horns coming up there, and you can see the anterior complex. This is the fox, that's the sulcus here, that's the cavum, septum pellucidum here, that's the corpus callosum, the 2 frontal horns, and this is the Toast sign. You can see the sylvian fissure is like a box, and it is open and not yet closed, and these are the temporal horns. And then we come back, so that's the coronal view of the fetus. So that's the coronal section from front to back. Now this is a sagittal view. We can see that it's a slightly oblique view. That is the sylvian fissure on the opposite side, and that's the cavum, that's the corpus callosum. Not a perfect midline sagittal view. You can see the cerebellar vermis here. This is the 3-horn view, the oblique view. You can see the frontal horn. In a couple of seconds you will see it again. The occipital horn and the temporal horn, and that's the sylvian fissure here. So it's a slightly oblique view, and I will try and freeze it at a particular point. Yeah, that's the 3-horn view. You can see the sylvian fissure, frontal horn, occipital horn, temporal horn. And this view is very good to see the margins of the ventricles, if there are any cystic areas or loosened destruction areas due to any infection. That's the corpus callosum, you can see it very well, and the cavum, and the opposite side lateral ventricle and sylvian fissure. The oblique view is very good to see the opposite side sylvian fissure also, because that can be difficult. And you can see the pressure the transvaginal transducer is putting on the anterior fontanelle to visualize the intracranial structures better. Now we are doing a power Doppler with slow flow technique, and again we can see that we are taking a sweep. You can see the pericallosal artery sweeping around the corpus callosum here, and we can see almost the entire corpus callosum. This is a split image with B mode on one side and the power Doppler with slow flow on the other side. You can see the indentation of the anterior fontanelle, and it gives a very good view of the corpus callosum from the anterior. When we visualize posterior structures, we prefer to insonate posteriorly if the fetus obliges us, otherwise anterior structures are better seen anteriorly. This is a C59 probe, so fortunately we can penetrate and see the entire head completely, and you can see the corpus callosum and the pericallosal artery. These are the striate branches here, and these sometimes undergo inflammation whenever there is a CMV infection. It's called vasculopathy or striate vasculopathy. So this we can see the power Doppler outlining the corpus callosum. Now this is a coronal view, and the coronal view with power Doppler is only useful for looking at the optic nerves. As you can see here at the base here, this is the circle of Willis, and at the base of the circle of Willis in the coronal view where you see the frontal horns and the cavum, you will see the optic nerves. It's a slightly oblique view, but you can fairly well see the optic nerves filling up that space. In situations like this, when we have an oblique view, we acquire a 3D multiplanar volume. As you can see here, that's the coronal plane, the sagittal plane, and the axial plane here. And we can then work on this volume and get the perfect sections as we want them in all the planes. So we rotate. Now we first magnify the image so that the brain occupies the entire space, and then we look at the frontal horn. We put our cursor on the cavum septum. You can see here. You can do a little bit of post processing. And you can see simultaneously on the Y plane the corpus callosum is seen very well. So you can scroll through the image in each plane. As you can see here, you've got the three coronal sections of row coronal sections, which I just spoke about, in the same volume. As you can see here from the occipital horns, you have the calcarine fissure, the interhemispheric fissure, and you come in front, scroll forwards, the choroid plexus body of the lateral ventricles. That's the corpus callosum and the cingulate sulcus here. This is the sylvian fissure. You can see the anterior complex, frontal horns, corpus callosum. And similarly, we can move to all the planes. So this is a perfect midline. We can magnify. You can even take it as a single image. And you can see the entire corpus callosum very well. So that's the corpus callosum here. You can see the entire body of the corpus callosum, the cavum septum, and you can scroll in and out of the image. That is the tectal plate here, That is the splenium, and that is the end of the corpus callosum. We can also do measurements. You can measure the thickness, and you can see that it's quite homogeneous. And this gives a perfect midline section, especially as you saw earlier, we could not get the good view of the corpus callosum because of the oblique position. So just by taking a volume sweep, we can do just the same. So that's the midbrain here, and the pons will be here. We have not focused on the posterior cranial fossa here. We are only focusing on the anterior cranial fossa. And that's the axial view. So we can then focus on the C plane, and you can see that again we are seeing the frontal horns, the interhemispheric fissure, the corpus callosum, the cavum, the thalamus here as you go down, and then the parieto-occipital sulcus, the occipital horns. And this is the high view, the ventricular view, that's the transthalamic view, and as you go down you will get we have not focused on the cerebellum here, so the cerebellum is not seen in this view. The advantage of 3D imaging is also that we can get a reconstructed view, so a surface rendering view. Now you can see that the green bar is up here, which is cutting. The cutting area is from here where we would take a section. So we need to change that, and we go into the render and we'll take the left to right, and then we exit, and then we go into taking a thinner section here. And you will see the corpus callosum is beautifully seen here with HD live demonstration. So that's the corpus callosum seen very well here. And you can scroll through the image. That's the occipital horn here, that's the temporal horn. So that's the 3-horn view. Corpus callosum in the midline, and the opposite side view again here. So that's a rendered image. You can even zoom it, and then you can identify the cavum septum, the tectal plate here, the midbrain, and then that's the vermis, but we are not focusing on it, so we are not getting a good view of the vermis. You can play with the light and highlight the margins of the corpus callosum. And that's the perfect midline. Okay, the other technique that one can use is Omniview if required. So now I am in volume contrast imaging, and you can see that a volume contrast of 2 gives me a slice thickness of 2 millimeter, gives me a good thickness of the corpus callosum here. And you can then take multiple sections with Omniview if you like. You can even scroll from front to back. And this is a particularly useful view, the coronal view. And you can see the same planes what we saw earlier from occipital to the calcarine fissure, the tentorium, and going forward the thalamus, and then the cavum, frontal horn, and interhemispheric forks. So this is a particularly useful view. You can also rotate the bar if you like and get sagittal views, axial views. So Omniview is really useful for looking at the same volume slightly differently. And then you can even make measurements. Oh, sorry. So that's the lateral ventricle. You can see that it's at the level of the parieto-occipital sulcus. The other advantage in having the 3D volume is we can do the tomographic imaging. So we can use the central point as the mid-sagittal section here, as you can see here, align it approximately. Take thin slices. And we get all the multiple views in the same box. So you just need to manipulate a little bit and then you will get the entire section proper. So that's the corpus callosum in the midline. And we can change the thickness of the VCI. We are on volume contrast imaging. This is 1 millimeter. I prefer 1 to 2 millimeter. And you can take thick sections to see the sylvian fissure here. And you can see here in the coronal view, the toast view, that's the sylvian fissure here from one side. And this is the three-horn view, and that is on the other side here. So we can extend it a little bit there on the other side, and that's the other side sylvian fissure. You can also get views in the coronal view, multiple coronal views. So the entire neurosonogram in one volume, and that's the axial plane can also be obtained. This is particularly useful when you have a good volume to scroll through the entire volume. You can do repeat studies, you can transmit the images, take a second opinion, and if you have missed out anything, you can do it again. And you can take measurements also. Here, for example, is the margin of the lateral ventricle here. That's the parieto-occipital sulcus here. That's the corpus callosum, forks, the anterior complex, the posterior complex, and the occipital horns. We have taken from posteriorly. We are now looking at the posterior cranial fossa here, and we can see that that's the vermis. So we identify the midline section by the presence of the corpus callosum and the cavum. That's the tectal plate. This is the midbrain. That's the pons, the medulla oblongata. This structure here is the fourth ventricle here, and this is the vermis here. You can see the fissures. That's the fastigium, and that's the tentorium here. So we need to do some measurements. We take the superior inferior diameter of the cerebellar vermis, anterior-posterior diameter of the vermis here. We can take the anterior-posterior diameter of the midbrain, the pons, and these are some of the measurements that we look at. And you can see the cisterna magna is here at that level here. You can also scroll through this image and get a perfect image. And then we can also take some angles. So that's the normal angle, is very minimalistic. When the vermis is rotated in an anti-clockwise fashion and the fourth ventricle communicates with the cisterna magna, it's usually due to a Blake pouch cyst. And you can also measure the area of the cerebellar vermis and relate it to the head circumference. The ratio is always less than 1. And then you can scroll through the volume and get the perfect view of the midline cerebellar vermis. We can render the vermis. That's the axial view, coronal view, and we are rendering the vermis here, as you can see here on the A plane, and the picture of the B plane is represented here. That's the vermis. It's not as good as looking at the earlier original image, but at least you get the orientation. You can see the fourth ventricle, the fastigium, the hemisphere, the different fissures of the cerebellum, the tectal plate, the cavum septum, and that again is the hindbrain, the midbrain pons, and medulla oblongata. And of course we can angulate a bit. Now that we have seen the two cases, we'll just see very rapidly 4 or 5 abnormal situations. These are the important CNS abnormalities that we look for. One is of course ventriculomegaly, then midline abnormalities of corpus callosum, holoprosencephaly, posterior fossa, cortical disorders. Of course we cannot go through all the abnormalities, but we'll just rush through them. So ventriculomegaly, any situation more than 10 millimeters, 10 to 12 is mild, 12 to 15 moderate, and more than 15 is severe. Of course it has implications of prognosis, and these are the various causes we need to look for. There could be hemorrhage, septo-optic dysplasia, agenesis of corpus callosum, it could be unilateral, and hemimegalencephaly, it could be CMV with calcification, and of course the lemon and banana suggesting that this is a neural tube defect. The corpus callosum, we have indirect signs, that is colpocephaly, or direct signs where we look for the corpus callosum directly. Here you see the frontal horns are separated from the midline, there is widening of the fox and colpocephaly, and the cavum septum is not visualized, and there is haphazard arrangement of pericallosal artery. The advanced neurosonogram shows us that the corpus callosum is seen, but it is small in some parts, and this turned out to be an Apert syndrome, typically with mittened hands. The coronal view, as I said, is very important to highlight the fact that you don't see the cavum here. This is agenesis of septum pellucidum or septo-optic dysplasia. The frontal horns are widened. In agenesis, again septo-optic dysplasia, typical box-like ventricles, holoprosencephaly, completely monoventricular cavity, semilomer holoprosencephaly communicating in the midline, cysts with agenesis suggestive of Aicardi syndrome. Posterior cranial fossa, very useful on neurosonogram. Here of course this is megacisterna magna with cardiac abnormalities. Then on the midline view, as I said earlier, if the brainstem vermian angle is altered, This could be inferior Vermian hypogenesis, agenesis, or could be a dandy walker depending on the degree of rotation. And the most common abnormality, of course, being a Blake pouch cyst. You can see the vermis is intact, it is rotated in an anti-clockwise direction, and it is an agenesis of, a Blake pouch cyst. And here again another Blake pouch cyst which closes at about 28 to 30 weeks. Now that's a dandy walker malformation with severe rotation, severe small vermis, and that is pontocerebellar hypoplasia seen here. Last slide here suggests showing ventriculomegaly, but only on the coronal view you can see that the parieto-occipital sulcus is not well formed here. So this is a cortical malformation, and you can see from the axial view this is just difficult to judge, but on the coronal view it is easy, and therefore it's very important that you do a detailed neurosonogram. When do we do MRI? Sometimes to confirm sonography findings, and additional information can be obtained in certain situations like hemorrhage, agenesis of corpus callosum, ventriculomegaly with no other features, genetic disorders, infections, or if there is difficult visualization on sonography, especially with oligohydramnios and high BMI. And of course, MRI gives better contrast resolution, and we don't hesitate to use it in about 10% of cases where we need more information. So in conclusion, basic and advanced neurosonogram are the fulcrum of investigations of the neural axis of the fetus. First trimester examination is exciting, but yet second trimester examination is the fulcrum. We use a lot of 3D and midline sections to look at the corpus callosum and vermis. Associated abnormality guides the prognosis. Follow-up scans are important to see progression. MRI, as I said, after 24 weeks in 10% of cases. And prognosis is good if it's mild ventriculomegaly with no other abnormality. Partial agenesis corpus callosum, prognosis can be uncertain, and of course delayed anomalies can have legal implications. So I thank you again for patience to hear this long workshop, and if there are any questions, would love to answer them. Thank you very much again.